Chef.
What's going on, mate? How are you?
Yeah, good, mate. How are you?
I'm very good, mate. Very good. Thanks for having me on again. And what did we just done a chat, didn't we? Who did we speak to again? Two amazing professors.
Unbelievable. The authors of TOWAR, that's just published in the New England Journal of Medicine, where they looked at pre-hospital whole blood versus component therapy. This is very topical at the moment, and we did a chat the other month on the SWIFT trial. And, you know, if people publish an article, sure, put it in some of the world's biggest journals, but also come immediately on the Pre-Hospital Nerds podcast and talk about it.
Well,
No?
that's what I reckon too, mate. How good is that you've got somebody that publishes in the New England Journal of Medicine, and then they go, hang on, no, let's go speak to Pre-Hospital Nerds. We need to tell them all about it so they can get it out to their listeners. This is just amazing, mate.
Exactly. And look, for those that don't know what the TOWAR study was, this has been highly anticipated. This is about 1,000 critical pre-hospital patients with hemorrhagic shock. And just to compare whether whole blood is any better than giving people components, isn't it? So, look, a fascinating podcast. Interesting to see these professors fight it out, I must say, in a friendly way. And, you know, when you've managed to get those two people in the room, let them work it out and just sit back and enjoy. I reckon I wasn't going to interrupt when the two of them
I don't think you could interrupt them. Two Americans in a room together having a chat. It's impossible to interrupt. But that's fantastic. That's what we love to see, that communication. And the other good thing that they got out of the study was looking at the age of blood products, whether that had an impact on whether it changed, coagulation profiles or anything like that with patients. So really a great episode to watch, learn, and listen in with.
Yeah, absolutely. So stay tuned, hang in there. It gets nerdy at times, but that's why we call Pre-Hospital Nerds, I guess.
100%.
See you next time, mate.
Good on you, mate.
Play the song. Wow. Chef, we're back in other episodes.
Mate, it's been a little while since we've done a recording, so it's good to be back doing some more recordings again here today. And we are joined by none other than good old Mark Yeazer from Pittsburgh. Thank you very much. And he's brought with him Sir Ramsey today, who's sitting front and center in front of him there. Also, we have Jason Sperry come over as well. Now, Jason, whereabouts are you from in this world?
I was born and raised in Pennsylvania, and that's where Pittsburgh is now. And so I've been worked in the University of Pittsburgh for the last 20 years. And here as a trauma and general surgeon, an emergency general surgeon.
Mate, I understand you've got a bit of a history behind you, and we're going to talk specifically today about how to pronounce this, the TOWAR study that's been done, which has been recently published in I think it was the New England Journal of Medicine. Is that correct?
That is correct.
So we're going to talk specifically about that. But Jason, just give us you tell me very briefly that you've got a bit of history there, but give me all those credentials and the experience and, you're sitting in ready to respond in ICU at the moment. Tell us a little bit more about yourself and your experience, please.
Well, yeah. So we do trauma and critical care. I do trauma and critical care here at the University of Pittsburgh. And so at least in the United States, trauma surgeons are in-house, and we consult orthopedics and other specialties when there's specific injuries, but we manage those abdominal, thoracic trauma that needs urgent interventions. And that's, so I'm in-house as the ICU doctor tonight, but one of my partners is the trauma surgeon that's in-house. We have to be in-house. We've been doing a lot of trauma critical care hemorrhagic shock trials over the last 10 to 12 years. And my collaborator, Dr. Frank Guyette, is at the Department of Emergency Medicine here, and we organize something called the LIGHTS Network, it's called Linking Investigations in Trauma and Emergency Services. It's funded by the U.S. Department of Defense, and we sort of run clinical trials that have, DoD relevance, and it's a communication from them of things that they're of interest. We design the trial, and then we execute it using the U.S. civilian trauma centers across the country. And it's international. It's been in Canadian, and we might be reaching out across the pond and could even reach out to Australia at some point in time. in the future also.
Wonderful. That's terrific. Alex, I think we're very lucky to have such distinguished guests to be speaking to on the podcast. So thank you both very much for joining us.
Yazer's the man.
Well, Sperry's the man. I'm just the guy from Canadian, as you just
Mate,
said.
I'm going to settle this. I think Ramsey's the man. So Ramsey, front and center, mate.
He's a man, that's for sure. Absolutely.
All right. So
Yes.
Hey, listen, Matt, before we get going, we got to give a big shout out to our friend Wade Wong in Taipei, who brought us together a few months ago.
Wade did a fantastic job over in Taiwan, got us together, had our opportunity to speak about blood and blood products and the administration of them and so forth with how our systems work, and definitely did look after us, didn't he, in Taiwan?
Yep,
Yeah.
he's the man.
He is.
If you end up in Taipei, ask for Wade. He'll help you.
Everybody will know him, especially certain areas and certain bars that you can go to. They know Wade.
Reputable.
Good on you,
That's
mate.
right. Beautiful. Now, TOWAR, congratulations. New England Journal of Medicine. That's not every trial that gets published there. It's got to be of certain sort of scientific rigor and certain impact and topical and what have you. So well done. What does TOWAR stand for? And why did he sort of do this trial? What's the background to needing to do this study?
Yes. So TOWAR stands for Type O Whole Blood, an assessment of age during pre-hospital resuscitation. So that's where the TOWAR comes from, Type O Whole Blood, the TOW, and then assessment of age, maybe an extra A in there, and then pre-hospital resuscitation. So it's not TOWAR, but TOWAR. We've done some other studies, PAMPER with an ER, or, early resuscitation, but we wanted the assessment of age, which was an important, it's age of the whole blood, and we can talk about that probably, but that's one of the more important aspects of the trial, which we, in collaboration with the Department of Defense, who funded the trial, was interested in. And that is the age of the whole blood product. If there's any reduction in its hemostatic capabilities as it ages in the refrigerator before its use. So that's where the TOWAR with an A came from.
I think that's a really important part. And maybe we can even start there if you want, Jason, with regards to the age of the blood product. So in general, I think we've spoken with Mark before about the length of time blood products can remain within a vehicle or in the pre-hospital environment. And obviously that is something that you need to look at is, well, how long can you leave those blood products in that environment? Do they then get shipped back to the hospital for use, or are they actually wasted and so forth? Because obviously we don't want to waste blood. So it's really important that we try.
I'm going to have to answer this.
Yeah, no.
This is gold.
This is real emergency stuff. No. We're going right to the scene here.
Yes. Yeah.
We could mute him for confidentiality reasons. This is
cut
so
this,
good.
We'll just cut this. That's fine. Yeah. No, you're going to put his head back on.
Snip, snip. Isn't that right, Sir Ramsey? Yes, you remember snip, snip.
That's going in.
I reckon all of this is going to stay in.
This is why people tune in, mate. It's not the science. It's the banter, man. It's the very, very witty banter. I loved how he said that he was born in Pennsylvania, and now Pittsburgh is in Pennsylvania. And I was going to say it's always been in Pennsylvania, but I don't want to throw him off his game, you know. Or from Canadiana. Too funny.
I'll unmute him. Hang
Yeah,
on, here we
on
go.
mute.
He's back.
We're back.
Did you tell them to give a unit of whole blood or just give component therapy? What did you tell them, Jason?
Well, I might have to intubate somebody, but
You might
right
have to
now
go.
I am okay. But if I have to, usually it happens make it midnight one time or two times, and I could come back. It might be a quick intubation and I could come back. I'm not sure if you guys are on a time.
Well, I think what you should do is just put a head cam on and then go down, do the intubation and talk us through the process as you're doing it, talking about blood products at the same time. That would be fantastic, mate. So while we've got you for the moment, mate, if you do need to leave at any stage, please just go. That's clearly not an issue at all.
And I, like I said, I'll come back but it's up to you. I want a good, whatever's best for you guys. I mean, I'll try to, I'm in the hospital all night. That's up to you, but you guys you're in the morning right now, aren't you?
Yeah.
Okay.
I'm about to head out the door for work. I don't know what you're doing at the moment, Alex. So
Yeah. No, well, yeah,
why don't we
could
just crack
find
on and we'll see what happens.
another
Yeah,
time.
for some reason I have to intubate, then I can either come back, might take 15 minutes, or we could do another date, or I'll work with you guys, whatever's best for you.
Let's push on now, like what Mark said, and we'll go from there. Thinking about the use of blood products and so forth, and their aging, and we were talking about how we don't know how long we can keep them on the vehicles for. We like to return them back to the blood bank. That is a process for you. Normally, you keep them on your vehicles for 14 days, I think it was, from memory. Would that be about right?
That would probably be out to, I mean, you can store it out to 21 days and 35 days, and it depends on what solution it's created in, or it's delivered in once it's donated or retrieved. Dr. Yazer probably is more familiar with that process than myself. But for this current study, the TOWAR study, all sites were using out to 21 days was the age. Some places use it out to 35 days based upon the storage media that they use. But for this study, it was out to 21. Some recycle it, yes. But for this study, we sort of wanted them to use it out to 21 days, if at all possible, so we could get a spread of the age for the study purposes.
Yeah. And so the age brackets that you talk about within your study, I think it was up to 14 days and then 14 days to
21
days. No worries. And so with your study, what was the evidence and what did it actually find with the use of the older blood products?
Now, importantly, the whole bloods. So importantly, we did a 2-to-1 randomization scheme. We did two of whole blood per one of component arms. And that allowed us to do an observational sub-study that's not randomized. We had to do high-level statistics to sort of compare. But we compared because there was no randomization for older whole blood versus younger whole blood. It's like it's within the arms. 2-to-1 randomization, we had over 600 patients in the whole blood and around 300 patients, approximately over 300 patients in the component. So that allowed us, the 2-to-1 allowed us more power to look at this age, this important age characteristic. And the trial showed it's like the curves are overlapping at younger whole blood, at older whole blood for 30-day mortality. And there's no difference in any of the secondary outcomes across age, which at least provides the best evidence that's available in a large observational trial embedded in a randomized trial that there doesn't seem to be any regression in the hemostatic capabilities. In a subset, we also did TAG and coagulation measurements and platelet assessment, and that's in the supplement in the New England Journal. It wasn't able to be in the primary paper because it had associated with some missingness, but it showed no difference in any of the coagulation parameters or platelet function. It might not have been powered. It was a smaller subgroup analysis looking at those laboratory measurements, but there was also no difference in any laboratory measurement across older and younger.
That is a very important piece of information to come from the study, is that knowing if you've got a unit of blood in your possession to go and treat in the pre-hospital environment or whatever environment that you're in, that essentially there is going to be no difference whether it's a fresh batch or whether it's a batch that's reached up to 21 days.
Importantly, remember the randomization, and there was the pre-hospital whole blood versus component, and then the patients got standard care in the hospital. So the pre-hospital was a small portion, so it could have been 1 or 2 units that were older or younger, but they might have gotten all old in the hospital. They might have gotten all young in the hospital. They might have got more whole blood. They might have got components. We didn't really. We recorded 24 hours, but we didn't control for it in the study any differences in hospital. But at least we didn't find. So we're looking at a small proportion of the blood products overall, whether in the age of them. And so a perfect world, the best study would be if we knew all the ages of all the blood transfusions they got first 24 hours, and we were able to compare. That may be relevant. So we may be looking at a small subgroup that might have not a lot of signal, but it's the best evidence we have.
I can tell you that the units we transfuse in hospital have an average age of 10 days. So they fall in the younger bracket.
It's older than I expected, Mark. I was thinking in my head, it was like 7 or 6 maybe, but, and we're pretty busy. We have a lot of massive transfusions and stuff, pretty busy hospital, but the more you use it, they'll be younger, I presume, if you use it more often.
Yeah, that's right. And so we do use it. We do use it quite a bit. But the average age is 10 days. So So what we transfused pre-hospital in TOWAR wasn't terribly dissimilar to what they're going to get in hospital.
It's interesting.
And the other important thing to remember was that the median number of units that the patients received of whole blood pre-hospital was 1.
Yep.
And so compared to the SWIFT trial, it was a smaller volume of pre-hospital transfusion, which isn't a knock. I mean, it's pragmatic. It's what happens. It's just that it was 1 unit.
We didn't require them to give 2 units. It was based upon hemodynamics and their standard air care, and so we did not dictate whether they received 1 or 2. That was based upon their hemodynamic status, and that was the same thing for components. They gave during the component month. They gave some had red cells and plasma. So we weren't able to. We didn't want to change. We couldn't change their standard care for the trial. We started using whole blood in the trial. There were 2 sites that were using whole blood, and they reverted back to component for the trial during those months.
I just want to clarify something. So a unit of blood here when you transfer a patient on HEMS in Victoria is red cell concentrate, which is around 250 to 300 mils. A unit of whole blood is a volume of 500, thereabouts.
55.
Yeah. Yep. So just for an understanding for those listening that there are differences, and when you talk about 1 unit, that will be comparable to perhaps given 2 units of red cell concentrate back here.
Well, it would be comparable in volume, yes, but not
Yeah.
in composition, because in a unit of red cells, it looks red for a reason. There's only about 30 mLs of yellow plasma in there, and in TOWAR, it was quite appropriate that the component arm received a median of 1 red cell and 1 plasma unit as well. So it was quite a good match between the 2 groups in terms of the components they received.
It was really whole blood versus whole blood like, except for some platelets.
Yeah.
That was the comparison arm. And that's because standard care, based upon prior trials in the past, that Air Medical are carrying plasma, are carrying red cells. You know what I mean? And some of that involved from other prior trials. One of which is the Pamper study, which showed. And they're all carrying TXA now, and that's from the patch trial. You know what I mean? Like, so a lot has changed in the pre-hospital arena, at least particularly on air medical transport services.
Yeah. Oh, fantastic. So that's if we take a step back, which patients are you guys trying to study? And so this is a pre-hospital hemorrhagic shock, and that's the holy grail, who's in hemorrhagic shock. And I think you guys had an interesting sort of definition of when to randomize them or when to start giving this, the cutoffs being sort of a tachycardia more than 108 or severe hypotension less than 70 systolic. But how to identify the correct patients.
Right. So we used the same inclusion criteria from a vital sign standpoint as we did in the Pamper trial that was published in 2018, and the same vital sign criteria. And they also had to need blood transfusion. So that was that was a little bit of additional. And we sort of used the Air Medical standard practice, and they needed to need blood transfusion and then have our vital signs. And most sites use the systolic less than 90 as needing a blood transfusion, not uncommonly. And you don't want to get too complex with pre-hospital vital signs during air medical transport. You don't want them to have to go through a 20 checklist. There's some exclusion criteria, but we wanted very simple inclusion criteria, and that's pragmatic, and that's what's best and allows for the smoothest because the pre-hospital environment is complex, as we all know.
But with any sort of definitive imaging or follow-up later on to say sort of who were bleeding, were they all bleeding?
They were not all bleeding. Let's look at general in their transfusion requirements in the hospital. There was actually red cells in the first 24 hours. The median is 1 in 2 units in component. I mean, so we're talking about some patients had hemorrhage, some patients not. There was death by exsanguination. There was a 9% and an 8% range, and so that's death by exsanguination. It was a similar numbers that had death by traumatic brain injury. And the in-hospital mortality, these patients succumbed in 20 to 25% of patients in hospital, and 11 and 14% in the first 24 hours. And so some of them didn't survive enough to get blood transfusion. So you can't use the blood transfusion numbers if you didn't live long enough. The curves, the mortality curves separate very early in the first, as they did in Pamper, in the first 1 to 3 hours. That can be severe TBI and that can be hemorrhage.
So looking at the numbers, I'm just clarifying, was it around 1,020 over the 3 years? Pretty much working out to be roughly one patient a day, pretty much over all the air bases that we utilized.
That was probably true. Yes, we enrolled 1,020 in the United States. When you do an emergency trial like this, we get approval from the FDA to do it under exception from informed consent. We have to get our FDA approval, and the patients, we try to notify families and patients as soon as feasible, either by telephone or in person, and they have the right to say no, they don't want to participate. So there was a certain number that didn't want to participate, 27. So we analyzed 993 patients out of the 10,020. There were some patients that we missed. We didn't miss. They were discharged before the 30-day outcome, and we imputed their survival. But that was like 20 patients total. And that was very few that we didn't have the 30-day outcome. So we enrolled 1,020. That's the intent to treat, a modified intent to treat, because some patients didn't want their data, didn't agree, and to be included, and that was 993 patients.
I'm not the research guru, but I wonder, when you talk about people not wanting their data released for that sort of stuff, I go, what is it that's being affected by releasing perhaps what your blood results without any identification of any sort? I'm assuming that's the case.
Yeah, no, I mean, but we have to notify, and some, families are not interested in, even if you explain it exactly as the potential, may have helped them, but they have the right to say they don't want to participate, obviously. Yeah, and that's very, we are very important, for at least in our system, and I think in all systems, and but that is part of our protocols, and required by the FDA when we do one of these types of trials.
Yeah.
And we document all that. We have all the communications. We get consent from LAR and then patient. If as soon as some of them have traumatic brain injury, so they might not ever be able to consent in the first 30 days. And we communicate by phone, and we do it as soon as possible. And we have all the records up front, and all the sites at our site we participated, and as well as all the 9 other sites across the country and in Canada.
So, Spirit, can I ask you, one thing that struck me looking at the secondary analyses by subgroups was that it looked like there was like a signal of benefit for components in the patients with the severe hypotension.
Well,
what do you think about that?
Well, I have thoughts. There was, if you go to table 1, this is the
Oh yeah.
This is the question for that
We
is
can bring up
that it didn't hit
table 1, yeah.
statistical significance. But if you go to table 1, which is up front,
Yeah.
you look at the groups, and there was no p-values less than or equal to 0.5. So the groups were adequately randomized. But there is, in the whole blood group, which, remember, it's 2 to 1. The confidence intervals are a little narrower in a 2 to 1. There's almost like, because we enrolled more whole blood patients, there seemed to be a higher injury severity score. Didn't hit statistical significance, 25 versus 23. They had a lower GCS, 11 versus 13. Didn't hit. There was no statistical significance when we're comparing 600 and 300. 600, 715 and 200 and some patients, and and so look, the number of intubations, if you go up a little bit, pre-hospital procedures.
Oh, it'd be next page.
Yeah, it's in the next table here. Yeah.
Intubation, 54% versus 48. That is a major predictor. So that's like 6%. There's a difference of needing pre-hospital intubation, which is a major marker. Now, there's 2 factors that had a p-value between 0.05 and 0.1. And we adjusted for those. That was in our statistical plan, that we would adjust for any imbalances, and we used less than a p-value of 0.1. And so those 2 factors we did adjust for. There were no differences statistically significant using a p-value of 0.05 across the groups. And so our odds ratios, adjusted odds ratios, and our p-values included those adjustments, as well as the cluster design. We had to adjust because it's a cluster randomized trial. So we had to do specific statistics. And so when you look at the percentages straight up, it can be a little bit misleading. And so the confidence interval and the p-value, ultimately incorporate the design and any differences across the groups with a little bit of imbalance. And so I believe the whole blood patients were just a little bit sicker, and it did probably pan out in the overall mortality, but there was no statistically significant difference in 30-day mortality across the arms. You can't really comment on that any further, but you can highlight that there were some. It seems like the whole blood patients were a little sicker, despite our cluster randomized scheme and doing the best attempts to keep them equal.
So again, coming back to the hypotension, and what does that mean for that group of patients?
Well, that if you show the odd, go down again and show the odds ratio, that in that small subgroup, there was it didn't hit statistical significance. There was no, but that error bar, 1.02 and 2.47 is just over 1. So it is just statistically significant in that subgroup, and it does favor a component 24% versus 34% in those patients.
Yeah, I thought that was really interesting. And do we know anything more about that subset of patients? Like, did they have, like, are these the patients that were getting intubated and had the higher ISSs?
Well, we have not characterized any specific subgroup. It's a small subgroup, but there was a significant number, 543, that had systolic less than 70. So it'll be a definite secondary analysis, and we will characterize that. Now, those patients might be significantly sicker in the whole blood arm, but obviously we didn't break that down. And these models are adjusted for based upon these are adjusted odds ratios with the 95% confidence interval.
Yeah.
So do you think there's a difference in the sort of hijack the podcast here, guys?
No, it's a
Yeah,
great
we're all over
question.
it.
I
I'll be
was about
taking
to
over now.
ask
I'm
it.
T-shirt
Yeah.
on the
host
way.
Mark, and I've heard that before, but Sperry, what would Professor Sperry, do you think there's a difference in the like what are we talking about? We're talking about a unit of whole blood that's got red cells, plasma, platelets, and we've got a unit of red cells that's kind of spun. It's got some stuff added to it, and we've got a plasma unit that was separated within 8 or 24 hours of its collection, and then we put it back together as we're after it's infused. Do you think these these components are the same as whole blood, or you think there's something different about the whole blood?
I mean, we've done a pre-hospital plasma trial, and that was statistically significant, primarily in patients with traumatic brain injury. We looked at the traumatic brain injury signal here, and it's with TBI, without TBI, there is no difference in that subgroup, because the majority of patients got some form of plasma, whether it was in red cell and plasma unit or a whole blood unit. But I do, again, overall randomized cohort is when you look at all patients, and when you look at these subgroups, you got to be careful, and you can characterize things. That hypotensive patient is not randomized. The less than 70 is not randomized across at the level of the arms. Those groups are probably going to be different. I mean, we attempted to adjust for that with those odds ratios and those confidence intervals. And so you just need to be careful, but it's important to realize if there is a difference in the severity of injury and they die early, and then whole blood versus component, it may be not due to the randomization scheme. It may be due to the difference in severity of injury. Hold on one second. Hello. Ready?
This is fantastic. We're going to mute him for a second for confidentiality. They are ringing up urgently to confirm the odds ratio. Professor Sperry.
No, basically, I'm calling his phone to make it look good. I'm calling him to make it look important.
Say what? I'm gonna have to go intubate somebody, guys. I will leave this on. It might be back in 10. I don't want to waste your time. I'm not trying to waste your time. I'm sorry. This is on a
Yeah, good. We
my
understand.
ICU call nights. I'll be back, and then I'll do whatever you wish. Continue.
Thank you very much,
Not a
Jason. We
problem.
appreciate your
Back in a
time.
second.
Thanks,
Thank you.
mate.
Cheers.
Congratulations.
Yeah, hang around,
Fantastic.
Sperry. I'll see you soon when you come back there. Okay. What do you want to do? You want to chill for a bit and see what happens?
Well, I think we can almost bring this home, wouldn't you? Like,
go.
and Mark, you're a co-author on this paper, and yeah, I can't say enough times that this is fantastic work. 1,000 patients who are bleeding pre-hospitally, and then enroll and randomize and write it up. So that's hats off to you guys.
There's a few other points I was going to bring up.
Yes, let's do it now.
So tell me when you want to start. Give me like your countdown.
We're going, mate. We're going.
Oh yeah, we never stopped. I love it. Yeah.
That's right.
So
the patient's still bleeding.
where I was going with that question about the plasma is, Swift showed that patients who received the whole blood, higher proportion amongst the patients who received whole blood, there was a higher proportion of those who had a higher prothrombin time when they arrived at the hospital. I think it was about 40% of patients in the whole blood arm that had elevated PT, like 30% in the component arm. And it got me to thinking about that. First off, I was thinking, well, who cares? But then I thought, well, maybe we should care. And so I remembered a study that we did in Pittsburgh. Sperry was on it too, where we actually looked at because in the old days, as you said, Matt, we used to recycle whole blood. We used to get it back at 14 days. We would take away the plasma, and we have a lovely red cell for transfusion. So we used to just bin the plasma, and we thought, instead of doing that, let's study it. I mean, let's see what's going on with that plasma. Is it good or not? And so we accumulated a bunch of these like supernatant whole blood supernatants, and we compared them to liquid plasma, that is plasma that's never been frozen. And interestingly, what we showed was that compared to liquid plasma that's never been frozen, the supernatant plasma had higher PT than that liquid plasma. And so it is potentially somewhat explicable that in patients who receive 2 units of whole blood pre-hospital, like it did in Swift median, it might have contributed to a prolonged PT. I don't know if that really contributed to bleeding or to death or to whatever, but it was an isolated finding. And some people have really seized on that, and they've thought, oh, well, here we go. Blood induces a coagulopathy. But what they didn't do was read the rest of our paper, where we looked at the other coagulation factors and things that are in that supernatant of the whole blood after 14 days. And in fact, we studied these parameters until day 21. And what we found, really interesting, was that the supernatant, as you would expect, had a greater number of platelet microparticles and bigger microparticles compared to regular liquid plasma. And that makes a lot of sense, doesn't it? Because for 14 days, that supernatant was swimming around with platelets, and the platelets were chucking off their microparticles, and the plasma was absorbing it. And we don't know exactly what the role of, or how to quantify the role of these microparticles, but we know they're really thrombotic, prothrombotic. So does having a concentration of bigger microparticles nullify the effect of the PT, of the prolonged PT? I don't know. I mean, they operate potentially on different parts of the coagulation cascade, platelets versus like primary versus secondary hemostasis. But maybe it compensates. The other thing we found, which was cool, was that the supernatant had a higher thrombin generation, much higher thrombin generation than the liquid plasma, and that again could make a lot of sense if the phospholipids from those microparticles are involved in the thrombin formation and generation itself. And again, these are lab tests, right? We're talking about lab tests here. The PT, what it was intended when Mr. PT invented it? Do you know what it was meant to be? It was meant to be a test of liver function. Like it was meant to be almost like an albumin, like or the AST ALT, like how well is this liver functioning? It was never meant to be a marker of like perioperative hemostasis. Never. We've taken it and the meaning, we've just like imbibed meaning into this test that it was never really intended to. And so, and you could argue we're doing the same thing here with the microparticles and the thrombin generation. It's all just laboratory tests. We don't really know what the significance for this is in the transfused patient. Nevertheless, it does show that there are differences, which is the point, that there are differences between the plasma that comes in whole blood and the plasma that is not stored with platelets for 14 days. And I think that could be an important factor in the non-coagulation related things that plasma does, such as its effect on the endothelium. And in certain patients with a certain endotype of expression of inflammatory markers along with brain injury, we saw in a subset analysis or a secondary analysis of PAMPER that those patients had a real survival benefit compared to patients who didn't have the TBI and that endotype expression. And that again, and that's PAMPER, right? So that was with plasma, like regular plasma, not the stuff that comes from the whole blood. So I think there's a lot of questions that we could ask about how similar are these plasma products for the patients. We can measure all the stuff in the lab, and that's really great. But here we have the potential, at least to try and differentiate effects of different types of plasma, if there is any. Like Barry said, in this trial, we didn't maintain the randomization throughout the hospital course. It ended at the hospital door. And so, as you can see in the supplementary material, that patients started to get a mishmash of products once they hit the hospital, which is exactly what we expected because it's just the standard of care. And so it could provide us with a really cool opportunity to tease out the effects amongst patients who only received whole blood versus those who only received components to see if we can detect any other meaningful signals that this plasma might be contributing to. The other study that I think is actually designed for something like this is called the TROOP trial, another randomized trial based, I think, in Alabama. And the difference between SWIFT and TOWAR and TROOP is that TROOP maintains the randomization through the hospital course for 4 or 6 hours, whatever it is. And so those patients are more likely to get more of what they were getting pre-hospital in the hospital. And I think that'll be a purer population. But I think we have already the laboratory foundations of differences between plasma and whole blood and plasma in just regular plasma. And perhaps we're seeing some difference clinically as well.
Amazing stuff. There's lots going on there at the moment, obviously. What is, at the moment, Mark, you're no end to the amount of papers that you got your name onto, I think, from last 360. No, hang on. Was yours
65.
365?
On a day, and then he's been snaking off for the other 20
That was a
years.
long year.
One day for a year.
Man, that was my wrists were, boy.
What are you up to at the moment, mate? What are you actively working on right now? What's your latest trial or latest research paper that you're working on?
Well, the latest stuff that we're doing is some more analysis of the de-alloimmunization rate in women. And frankly, that could occupy a whole podcast. We've been trained to, and exactly right. Exactly what Sperry was saying. I agree with him completely.
Yeah.
And I am the greatest.
You are a different person when he's back in the room.
It's just like what he was saying about what a great collaborator I am and a good-looking guy.
Yeah.
Just in time, exactly.
That's right. That was very
slick,
quick
intubation. Yeah, it was.
First time.
Now, did you give them whole blood or components?
But down the ET tube, that would be bad. Even I know that.
Yeah.
They were not. It was a medical intensive care unit patient, not a surgery patient.
There you go. Excellent.
Sorry, I want to ask you to get your sort of broader opinion, taking over my role as host again.
That's great.
One thing that really impresses me about both SWIFT and TOWAR is that we didn't have a saline arm. And what do you think this tells us about where the field is going, or in fact where we are?
Yeah, I mean, it would be like having a cancer trial and then giving no treatment in one arm, and then versus 2 types of chemotherapies. I mean, like having a saline arm or a no blood arm. I mean, yeah, there would be a higher mortality. So this is an interesting. So PAMPER trial published in 2018, pre-hospital plasma 2 units versus standard care. Some sites on either side had red cells. A lot of it was crystalloid. The control arm, the ones that either got crystalloid and or red cells in crystalloid, had a 33% mortality using the exact same vital signs as TOWAR. The overall mortality for TOWAR was 24%. With plasma arm a little lower and whole blood one percentage point higher. And so 33%, same vital signs, 10 years apart, 9 to 10 years apart, depending on enrollments when they started. A decade later, That's pre-hospital TXA. That's no crystalloid. That's blood products. That's plasma. That's early intubation. That's preventing decompensation in TBI. There's all the things that we're doing differently in pre-hospital. And now it's same identical inclusion criteria, even a little harder. The need for blood transfusion was part of the in the sense inclusion criteria. Now 24% overall mortality. It's 10% mortality difference. I mean, and interestingly, the Pamper trial, the interventional arm, the mortality was 24%. And that was the plasma arm. That had plasma, red cells, and some, a little bit of crystalloid. It's moved. Now that's everywhere. Now it's just, things, pre-hospital care has evolved. And it's not just blood products. I think it's a major part of it, how we're transfusing, keeping them alive to the OR and allowing us maybe get them off the table. But as you can see, there's 25% that don't make it off the table. They don't make it off beyond 2 hours from arrival. Those curves of the early dropping, not the separation, but because there's no difference between the curves statistically. But the drop is they're all dying in the first 1 or 3 hours. So we still have room to do stuff in the pre-hospital arena. I mean, some hemorrhage you can't control, some TBI you can't control, herniation, arrest, all sorts of stuff. But there's still room to grow.
Yeah, fascinating.
But it's not amazing how we've moved on. I mean, sitting was like what was the thing, and we gave liters and liters of it, and now we're not giving as much. I mean, I saw what the patients here had, 400 mLs of saline or something.
I mean, pre-hospital, they might get, and they're not getting it in the bay either, and they're not getting it in the OR. They're getting very little. They're getting, component resuscitation or whole blood resuscitation in either fashion in hospital. So the troop trial. So we have SWIFT and TOWAR, both showing no difference. You can't really go much further. There's some subgroups. There's some reasons maybe that there is a little bit of separation between the groups. But I mean, the troop trial, which is coming out, up to 8 units of whole blood versus component, and that's in hospital, early in hospital. That might have a dose response, a lot of whole blood, a lot of improved resuscitation. So that might be where there's some signal and some benefit. All the in-hospital whole blood observational trials have shown benefit. And so it may be that pre-hospital, unlike plasma, where it's good to give it early, particularly in traumatic brain injury, if you believe Pamper, which I'm a believer, obviously. But it may mean that, plasma or component, it might not matter, but it does matter for the Department of Defense, for the military. The military in a far forward situation in Ukraine, they're not going to have components in a far forward situation. They don't have a choice. That's why the whole blood sub-study is so important, actually, because it showed that there's no major difference in only the small number, the small volume that they received pre-hospital, but early, that there's no difference in outcomes across older and younger whole blood in the pre-hospital environment.
Oh, this is fascinating. Just to that thing you were talking about, sort of 10 years ago, the mortality was in the mid-30s, and now it's down to 24. So that's 10% reduction with everything that's been introduced and learned over that time. But then in your study here, you guys sort of based the sample size based on a 10% difference, that it would drop from 26 to 16%. And I guess this is now criticism, just a sort of interesting question with any trial design, because if you say, look, this whole bloody might improve it 2-3%, and if that was true, you'd take that as a win, but then you'd need 20,000 patients, and then you either got to go across the world, and then people argue, well, the setting doesn't apply to us, or you do it in your own setting, and then you got to do it for a decade, during which time things change anyway. So, yeah, what do you reckon?
You're right. We powered it based upon Pamper's numbers, and that's an estimate, and you hope. And when we were planning it in 2022 or 21, plasma wasn't pre-hospital very commonly yet, even though Pamper had been published, but it was just starting. Most places were having red cells, and so we based it upon real numbers, our power analysis. And then we increased the sample size of the whole blood arm, and that was going to increase the power of the overall, because it would have been the 10% mortality delta would have given us, that's 340 some patients in each arm. But we doubled the 340 in the whole blood to do that. And that increased the power overall. So we even had more power than the 10%. So we started with that number, improved upon it, and thought, maybe we're even going to have more power than we did. Yeah. And you're right. If you really wanted to do a crash type 2 trial and you want to enroll 20,000 patients, yes, that's a lot more money from the trial, and you can't execute it in a 4-year window. When you add, in the United States, you add exception from informed consent, which adds a year of notifying the community and a whole bunch of other requirements by the FDA, which is appropriate because we're doing things to patients, without consent in an emergency situation. So the time frame is 4 to 5 years. We finished in 3.5 of clinical enrollment, but we had a year of uptime. Friend, if we doubled the patient population, we'd still be. So would Swift. Swift would still be rolling. So would TOWAR. Now, it's probably important. We've talked with the Swift people, and we're probably going to harmonize both data sets. There'll be differences and pre-hospital time. There'll be a whole bunch of things, but we're probably stronger together than separate. And so we're going to be meeting at the THOR meeting in Dublin, Ireland, and we're going to talk about, again, I'm not speaking on their behalf, but I had conversations with them, and that we might maybe consider maybe harmonizing some of the data and analyzing it together and see what comes up. Assume it would be somewhere between our results. They had a little difference. We had a little bigger difference, but ultimately when you combine, you get more power.
Yeah.
It might be interesting to see what we find together.
We'll be happy to share the results.
Yeah, these discussions are interesting, aren't they? And it certainly makes me look at some of the pre-hospital practices here in Australia with regards to normal saline administration. That is, for road-based ambulances, probably still the main, obviously, fluid administration that's given in certain or most circumstances. And then, obviously, they have specialist units which will transport blood to the scene and so forth. And it's probably going to take us a little while to evolve with that. So very interesting. Now, when you go over to Dublin and Ireland, is the plan to split the G? Have you heard of that one?
No. Let's split the G.
When you have the pint of Guinness and you've got to be able to drink it to the point that you get the level of right down into the middle of the Guinness.
I heard Yazer's a lightweight, actually, when it comes to Guinness.
Drink me under the table. Yeah, we'll go to the snug, and you can. But if I pass out, you got to pay the bill.
That's fine. That's fine. Sorry, that's fine.
Alice, do you have anything further?
Yeah, hundreds of more questions, mate. So let's keep going. Now, look, we'll leave it at one more, if you don't mind, and then any sort of takeaway you guys want. So just the primary outcome, 30-day mortality. We would have spoken about this last time, Mark, but I mean, is it reasonable to think that an early pre-hospital intervention like that would affect the outcome a month down the track?
Okay. Yeah. Pamper. That's my answer.
Good. Done. We're wrapping up. Yeah, fair enough.
That settles it. Yeah.
I have an explanation. So if we did a trial and the primary outcome was 24-hour mortality, you could pull up the survival Kaplan-Meier curves, and we'll see what's at at that first separation in the Kaplan-Meier, right in the first Kaplan-Meier, very early, right there. Now there's a tiny little, and then follow it out. So right there, there's a little difference. Follow it out. It's pretty much maintained. You know what I mean? So the mortality occurs early, and I agree that earlier outcomes when it comes to hemorrhagic shock are important. But if we published a study and it showed a difference in 24-hour mortality, but no difference in 30-day mortality, who cares? That's like 6-month GOS. So patch trial, and I'm not critiquing this, but their GLOS, they save lives at 30 days. But their primary outcome is 6-month Glasgow outcome score. There was some missingness, but there wasn't improved Glasgow outcome score. There wasn't. So you're like, trauma research has to go in steps. If you don't get them out of the ambulance or the helicopter to the trauma bay, you don't live. If you don't get them out of the trauma bay to the OR, you don't live. If you don't get them into the OR to the ICU, you don't live. I totally understand. It's in stepwise, but we have used 30-day mortality more commonly because I feel a little, picking your primary outcome to see if it hits. But the 30-day doesn't work. It's also relevant EFIC. It's a very good outcome. The FDA likes 30-day mortality. If you do 24-hour mortality, you can do it. So some of the things are regulatory that makes things smoother and easier. And we also are pampered by the PAMPER trial because we hit at 30-day mortality. And so I have another trial coming out, soon. Cavalier. It has 30-day mortality as its outcome, not 24 hours. It's a hemorrhagic shock trial. I mean, and so we'll look at this 24-hour mortality. We'll look at the whole Kaplan-Meier curves, but I don't know.
If patients were still bleeding at 30 days, I think that would be a very relevant endpoint, but luckily they're not. And so, the idea that the very first thing we do is going to affect them a month later, it doesn't register. It gets them to the next phase, and then we've got to do something about the TBI and the MOF and the sepsis. And transfusion can't be expected to be some, frankly, miracle that gets patients through all that stuff.
I disagree. The
It's a bundle of
ICU,
care.
your volume of shock from the time of injury to landing in the ICU, the volume of shock leads to differences in outcome. If you are in worse shock, if you bled more, if you did, you know what I mean? You stopped hemorrhage not as fast. Those things that occur in the first 6 hours affect 30-day mortality. I believe they have an ultimate outcome. So it's not that the intervention is just in the pre-hospital. It's if whole blood reduced the need for subsequent transfusions in a large number of patients, and then it improved their shock better, did something early on, it will have an effect on the ICU stay, their subsequent coagulation parameters, and ultimately the 30-day mortality. I mean, in the PAMPER trial, it separated and stayed stable. In the whole blood, I don't think 30-day mortality is a detriment. I think it is appropriate because hemorrhage, occurs early. It wouldn't have hit statistical significance at 24 hours. You can look at those numbers, look at the secondary outcome table. You can look at 24-hour.
Yeah, and that's all true, but I think that's because we're transfusing a small volume in both arms of very similar products.
One table down.
So,
this is pre-hospital.
That's what I'm saying is
pampered.
that we might not have fixed that quantity of shock with the small quantity that we transfused, and so that's why the results are so similar.
I agree.
And the other problem, or the other thing that I was going to point out, that is some people think, just go back to that, Alex, there, to A there, is this idea that there's excess mortality in the blood component group. It didn't reach significance at any time point. But if you believe that whole blood is making things worse for patients, which one could look at this graph and say, then I would ask you, well, what's the mechanism for that? Because if you look in the supplementary material at the adverse events, the thrombosis and the differences in failures of organs, there's no difference between any of them. Between the two groups. And so if one really is proposing that whole blood is worse, it makes things worse in a way that doesn't create a measurable adverse event and then kills the patient at some point later. And I don't really know anything like that, except maybe a crack on the head or something like that. I mean, that would be a really weird way to die, wouldn't it? To not have any measurable adverse event and then suddenly bang.
Well, mortality is the adverse event in a sense. You're thinking that something led to the mortality of the whole blood. The drop in curve in the first hour of arrival, which is when you show that Kaplan-Meier curve, in the first 24 hours it drops, then it plateaus, and there's no and this had blunt and penetrating injury. I agree that it might, as long as we're giving blood products, it might not matter in the pre-hospital setting, actually, and at this point in time. So we need to keep pushing the limit. We might have done the best we can from 33% controls in 2014 to 18 when we enrolled, and we've got it down 10%. Now we got to, unrelenting hemorrhage that 2 units. You can't do a massive transfusion on a helicopter. I mean, you could carry a lot of blood products, but you can. But if you're chasing your tail, get them there as fast as you can. You push the diesel fuel and you get them there and get into the trauma center and you get into the OR as quick as possible if they're bleeding. Traumatic brain injury, you can't tease that out. We can measure GFAP measurements now, and we can predict that maybe in the pre-hospital centers, in a site soon, where we might know TBI, yes or no, it's still going to be fast. You got to get them to the trauma center as fast as possible and keep them alive. So we're making baby steps, but we still got some room to go. That's for sure.
Yeah, and I think that's the point is what I take from Swift and Tower is some blood product is the way to go. I mean, whole blood is going to be the most convenient product, obviously, because it's one bag, it's got everything in it. But if you can't get whole blood, give them plasma, give them red cells, give them something.
Well,
but if you want to get the same results that we had in Tower, it's got to be balanced. So if you want to expect the same result, it's got to be the 1 unit of red cells, 1 unit of plasma, because we didn't look in this primary analysis at just what happens if patients get one or the other, or whole blood. So this idea of giving the idea that balanced resuscitation is key up front is what I take from these studies.
Yeah, no, and I agree. I would. So is it easier? So on a U.S., I can only speak on the U.S. system. Is it easier to have helicopters? Probably, or medical transports probably could have 2 red cells and 2 plasma. They probably could have that. No problem in a cooler, but there's labor involved in that. There's monitoring it. There's keeping in a refrigerator, keeping in a cooler. Pre-hospital though, on a helicopter, but a ground ambulance, you can't have that much blood out there that's wasting on an ambulance that might see 2 trauma patients in a year. You know what I mean? Or maybe 4 trauma patients. That's freeze-dried plasma or spray-dried plasma. That's a game changer. No refrigeration, 2-year. Australia, do you guys have freeze-dried plasma?
Yeah.
U.S. doesn't have it yet. We're going to be doing a study on it here in 2027.
We did a feasibility study with its use in HEMS here in Victoria.
That's good. We're going to do a definitive one for spray dried and try to get it to market in the U.S. That's the game changer, because then, and the military doesn't have any options. They can't get components in China or in Ukraine in a far forward situation where we don't have air superiority. The only options are going to be component, and then it'll be, when we don't have refrigeration, we don't have the ability to store it, it'll be freeze-dried. It'll be camping food plasma, which is, it's great. That stuff's magical. And so,
yeah, it's better than saline. That's for sure. I mean, it's pampered.
Dude, yellow. Period. I'd go yellow first, man. I'd go yellow first. No problem. Even in a helicopter, I'd probably go yellow first before red. I don't know. Plasma's
But
magic.
going back to that secondary analysis of pamper you talked about, the worst was the saline and then the individual components. And the best outcome was the red cells plus yellow. So
whole blood like resuscitation.
Yeah.
Couldn't agree more. But that's refrigeration and a donor. You know what I mean? It's hard to make synthetic plasma. They're working on synthetic platelets and synthetic hemoglobin carriers. It's really, they're not going to be able to recreate magical plasma. That's going to be freeze dried. For blood products, someone's always going to have to donate plasma, probably.
Yeah, I mean, the point is,
get rid of the donor. You get rid of the donor. You have synthetic platelets and synthetic red cells in the future, and it's a cakewalk.
But until that time, I still have a job.
You do.
Professors, thanks a lot. This is fascinating. Matt, you've got to go and intubate someone, do you?
I've got to get out on the field myself now, and I will be going, hold off on that normal saline. Let's get them to hospital. Or bring me that blood product straight away.
Get some whole blood, get some plasma, some red cells.
Fuel.
Yeah.
Diesel fuel, baby. That's what you need.
Yeah. My saying is bright lights and cold steel. That's what the patient needs. Get them there as fast as possible, mate. So
I agree.
Once again, thank you very much both for your time. We really do appreciate you coming on and sharing your study with us on Pre-Hospital Nerds. And thank you very much again. We'll speak more in the future. Thank you.
Cheers, guys. Have a nice day.
Yeah, thanks. Thank you.
Bye.
You too.